Good afternoon, everyone. We're going to allow a few minutes to have everyone be able to log in and join us, and we'll go ahead and get started with our conversation with Dr. Abel in just a minute or so. Just a couple more minutes to make sure everyone has logged on, and then we'll get started. All right, everyone, good afternoon. I want to start off by introducing our special guest today to speak with us in our next series of Conversations in Care. Thank you for joining us today, Dr. Abel. I want to do a little brief introduction. We're so excited to have you with us. Dr. Lillian Abo is the Associate Chief Medical Officer for Infectious Diseases at Jackson Health System. Dr. Abo is also a professor of infectious diseases at the University of Miami Miller School of Medicine. Dr. Abo is originally from Caracas, Venezuela, and received her medical degree from the Universidad Central de Venezuela. She completed an internal medicine internship at Jacobi Medical Center in New York, an internal medicine residency at Mount Sinai Medical Center in Miami Beach, and a fellowship in infectious diseases at Jackson Memorial Hospital. Throughout the pandemic, Dr. Abo has been one of the most trusted medical voices in Miami-Dade County and beyond. She is part of Jackson's clinical leadership team, helping guide decisions for the health system related to COVID-19. Dr. Abo is regularly featured on local, national, and international media and as a medical expert. We are so grateful to her for joining us today for this important conversation on COVID-19. Welcome, Dr. Abo.
Thank you, Flavia. Thank you to you, to the foundation, and to all the people that are here listening today. I hope I can enlighten you a little bit. I can answer as many as your questions, and it's a pleasure to be serving Jackson and our community.
Thank you so much. You know, Dr. Abo, we get phone calls every day at the foundation from donors, partners, vendors for the system, employees, everyone, right? Thinking we may have additional information. I think sometimes we're medical experts ourselves answering the phone, and I'm always deferring questions. So I thank you for helping me answer those questions oftentimes when I reach out. And hopefully today we can address a lot of those questions for many of the folks. And I think we'll just dive right into it, right? Everyone is really, really anxious still about this Omicron variant and what it is and how this surge has affected South Florida. So for most of us, it came out of nowhere in December. How has this variant been different than previous variants of COVID-19?
So, yes, there is a lot of anxiety as most people imagine that a pandemic was going to last 1 or 2 months. And then when you see this is dragging for 2 or 3 years now, then people are like, well, when are we going to see the end, right? Most crises, when you have a hurricane, it's like a few days, it's devastation, but then everybody's working on the recovery. Here, every time we're working on the recovery, sort of like a new tsunami comes, right? A new wave, and you're like, oh my God, I just rebuilt my house and now I have to rebuild it again. For us, Omicron, we started to get the first information around the end of November from South Africa. And one of the things that we have been doing as scientists since the beginning of the pandemic is we don't only check for tests, antigens or PCR, but we do what we call genome sequencing. And that has been really key in tracking the different variants and see if there are mutations. And this is what we call the variants of concern or the variants of interest. There are multiple other variants that are emerging, but they're not concerning enough. They're not as infectious, etc. What happened in late November is we started to see a spike of cases like what we're seeing now in the US, but in South Africa. And the alerts started to go around the world like, oh my God, something bad is happening, because they went from having it totally under control to this huge spike in people. And the first information that we hear in early December is, well, most people are doing great. We're not seeing a lot of people dying or hospitalized. So I think that there was a double message there, sort of downplaying how severe this could be, but also giving some reassurance like, hey, don't go in panic. Most people will overcome this, right? The CDC starts getting the information, and we start since December. We were constantly sequencing for the last 2 years, and late November we had not found any Omicron. Early December we started detecting Omicron already here in Miami. So as soon as we started seeing the Omicrons, it started going from 10% to very quickly 40%, to the next week 80%. It happened in a span of 2 weeks. We saw that our sequencing was showing more and more Omicron taking over Delta, which is exactly what happened in other countries. What is different from Omicron? There are certain differences. There are differences in the virus itself, and there are clinical differences, which is what most of the people in this webinar want to understand, right? I'm not going to go into the nitty-gritty details of the mutations, but when you have a virus, you really need to understand that these are like living beings, right? So viruses change and adapt to the environment, and both virus and bacteria have been longer than us on planet Earth. So they're very smart. They know how to adapt and to survive, right? So the virus has been mutating, and what we find is that there are mutations in what we call the spike protein, which is what the virus attaches, in the human cells. So if you change the shape of your spike, that means that the human body cannot recognize you as easily. So it does what we call evading your immune system. You have antibodies that say, oh, I recognize a round shape. Well, now the virus has a triangular shape. So now your body's like, is this a triangle or a circle? So that sort of causes immune evasion. What happens with that? That people that are vaccinated are still, some of them are getting infected. So the vaccine is protecting you from severe disease and death, which is amazing, right? Because 2 years ago, if when the pandemic started, we had Omicron, it would have been catastrophic. Okay, now we have a larger percent of the country and the population around the world either previously exposed or vaccinated. So that really helps us fight this variant. On the clinical side, what we are seeing is most people that are vaccinated, most of them are getting mild symptoms, but the symptoms range from a scratchy throat from 1 day to some people who are getting a bad cough and fever for several days and headaches that don't go away. And these are completely healthy people, no history of obesity, no hypertension, nothing severe, young, in their 40s, 30s, 50s. They're still getting sick for a few days, and they tell you, this is like a really bad flu, like a bad cold. Then we have another group of people who are vaccinated but are immunocompromised, the transplant patients, the cancer patients on active chemo. Those are getting sicker. Some of our transplant patients are hospitalized. Some of them, even on day 10, they get worse. Some of them are in the ICU, and some are dying. And that's really catastrophic for us, because we're trying to protect the most vulnerable in our communities, right? That doesn't mean that you can't go on with your life, but we really need to be, socially conscious that we need to take care of everyone around us. And then we have the unvaccinated, the people who have still not getting vaccines, and we're seeing those very sick, some of them in our ICUs. So the vaccines are working. There's still people that are skeptical, and I'm not going to be able to convince everyone who's skeptical at this point after a year. If you don't believe in vaccines, you need to come around with us and see the patients so you understand why we're so pro-vaccination. The masks do work, and it's very important to use the right mask. And I'm going to pause there.
No, certainly. So you mentioned what the most common symptoms are, right? And we've heard everything from a variety, like you said, a scratchy throat to someone that gets, a migraine that won't go away. Some folks are even saying that they're losing some, taste and smell. Are these symptoms similar to the other symptoms of the other variants, or have we seen something specific to this variant with regards to a symptom that may be different?
The only symptom that I have seen a little different is more headaches with Omicron. I can tell you the loss of smell and sense, we have seen it with all the previous variants in the original strain. In some people, the loss of smell can last several weeks, over a month, and it's usually reversible. What we're also seeing is more children infected with Omicron because it's so transmissible. The way Omicron transmits compared to the other variants is more like measles, which is a highly transmissible infection. With the previous variants, the attack rate was less. So let's say you were at a party with 10 people, maybe 2 people would have gotten COVID at the beginning, maybe 5 people would have gotten COVID during Delta. Now we see that the entire party gets it, or 10 out of 12 people get COVID. So a lot more people are coming infected when they're gathering or living in the same household that we were seeing before. That again, there are exceptions. There are people who call me and said, I have it and nobody else in my family has tested positive. Everyone vaccinated. But there are others that I'm seeing that the entire household is getting infected. In terms of other symptoms, what we're understanding more as the pandemic has evolved is the long COVID syndrome. So there are some people that these symptoms are lingering longer. And there's new data that the virus not only attacks your airways or your lungs, but it's going to different parts of your body. So a new paper just came out this weekend showing that it can go to your brain cells as well. And we're seeing the same brain fog that people have when they get chemotherapy, what they call chemobrain. We're seeing it even in children. It's affecting the neurons, and the neurons is really, it's affecting the myelin. So when it affects the myelin, which is sort of the conductor that surrounds the neuron, if that is being infected and affected, then your nerve conduction is much slower. So that's why people are feeling that, and we're seeing that in children as well. So I don't want to downplay it. I want to tell you, we need to be very careful because this is not over, and we still have over 400 patients hospitalized across our health system, when in November or the first week of December, we only had 40. So this is still ongoing, and it's slowly improving, but not completely better.
And for those people that, because I think I probably know, right, a ton of people that have been infected this time around, let's just say that. And for those people that say, all right, I think I had this variant, right? I'm not really sure what variant I had, but the likelihood is that they had this one right now. How safe are they moving forward? Because I think the most common question that we get is, okay, so I just had COVID 2 weeks ago. I'm good now. I don't have to worry about anything for at least 6 months, right? That's the most common thing that we hear. Is there any truth to that?
No, and the answer is we don't know with certainty, right? So there are a couple of jokes, right? So people say, if you don't know someone with Omicron this time, it means that you don't have enough friends because everyone around you has it or knows somebody who has it, right?
Right.
So yes, this tells you how contagious this variant is. What we have learned from previous variants, right, is that we thought that people would not be getting infections within the first 3 months. So the CDC original data and the WHO were showing that if you got COVID in January, you at least for 90 days are protected. Your antibodies should work and should prevent you from getting another COVID infection. We recently had, again, in most immunocompetent people, that should be true. Most immunocompetent people, we don't see reinfection within 90 days. Not 6 months, 3 months. However, we have seen people who got Delta in September and now had Omicron in December. So there are reinfections. And if you even look at the data from South Africa, there were data from people that got the Alpha, then they got Delta, and then they got Omicron. So some people have had COVID up to 3 times. So what we're learning is not everyone has this long-lasting immunity or lifelong immunity. They probably are getting it milder, but they are still catching it. So I would tell people, wear your mask and still be cautious, even if you already had it. And a lot of people have told me, oh, I just want to get it and get over with it, right? They're saying, oh, if it's just a little cold, if it's the best version of COVID that you can get, let me just get with it so I can drop the mask and just live my life. And unfortunately, I always say, COVID has made us very humble. It's a Russian roulette. You can get COVID and a scratchy throat for one day, or no symptoms and asymptomatic, or you can get very sick. And if you're asthmatic, you can have an asthma exacerbation. As I'm telling you, healthy people with headaches for a week or 2 or a month. So don't play with it. That's what I would say. And if unfortunately you already have it, you still need to take care of yourself.
And how long do experts like yourself think that this current surge is going to be around for, right? We keep hearing on the news, it's either peaking now or peaking in early February. This should all be done by March. What is the real talk on that?
So it's hard because there's so many variables that come into play. And I always say that we don't live isolated in Miami bubble, right? We're a world and we are interconnected with people that come from other parts of the world and travel. And we have cruise ships and we have airports and we have, different frontiers where people are coming from other parts of the world. So it's like with the flu, as some things get down here, they go up somewhere else in the world. So it's hard to tell you an exact time and date that the wave will be over. What I can predict based on the evidence that we have, all our previous waves have lasted around 6 to 8 weeks in terms of peak and surges of hospitalizations, and then things calm down. And then I feel like we have maybe another 1 month or 2 months of like calmness before another wave, comes over. But it's usually 6 to 8 weeks that the crisis goes on, right? That's what happened with the original strain, and this is our sixth wave, and it all look around the same. Now, CDC initially in December predicted that the peak will come around the end of January, sort of early February, and then we will start to see it go down. When the CDC was saying that, Florida was already on the rise, and Miami has been leading Florida in terms of more cases than anywhere else. So I think that our peak was just over in the last couple of days, and now we're sort of flattening and starting to see the downtrend. And this, until it completely goes down to where we were in November, it's going to take some time. Because if we have 470 patients in the hospital compared to 570 that we have a few weeks ago, we still have 4 to 5 weeks to go until it starts to normalize, so we can get under 100, and then 6 8 weeks until it gets completely to 50. So that's what I expect.
Yeah, are there any, I guess, conversations? I know that in South Africa, obviously they're ahead of us. In the UK, they were ahead of us with regards to this surge. Are we seeing any other potential surges or variants coming next? Because I know, like you said earlier, it seems like we get about a month or two, maybe 3, sometimes of a lull, and then something picks up. Or is it too soon to tell yet?
It's too soon, but I think we will get another variant. Between now and the end of the year, there will be another wave. Why? The majority of the world population is still not immunized, either naturally or through the vaccines. There's still a lot of people out there. There are a lot of countries that don't have the resources that we have. And still in this country, we still have a large proportion of people that are not vaccinated. So the latest data estimates that about 20% of Americans have had COVID. In Miami-Dade, as of a week ago, 30% of our county was infected with Omicron. Or so 30% infection rate is very high. In November, early December, we were 3%. So it's going to take some time for these to be over, as I mentioned. We're starting very high, so it takes time to go down. And can the virus continue to mutate? Yes, the virus can continue to mutate. Our hope is that this eventually becomes like a flu virus, that we can get a vaccine once a year, or not even, right? And get over with it. But I think it's going to take another year. It's going to take until 2023 for us to say this is over.
Oh, that's difficult to hear.
I'm sure
it is.
It's difficult to say it too, but
Yeah.
I just downplaying it, I don't think helps anyone. I rather know that we need to embrace this for another year. If you're going to travel, you're going to have to wear your mask. You're going to have to get tested. If you're going to do gatherings, do it, safely. And again, when we have this low transmission, go out, do more. When transmission starts to go up, put your barriers up again. And
Right.
it's a lifestyle. I put things always in perspective. My grandparents are Holocaust survivors, and they were in concentration camps. And when you're in a war and you don't know when the war is going to be over, and when you don't have food and you don't have a home, and you lose everything in life, you put things in perspective. Most of us are fortunate enough to have a home, to have a job, to be able to help others. Many of the people who are in this foundation are helping the community. So we need to be grateful for that and say that we have blessings in life, that we can continue to help people, and this will be over. It's not a war. We will be able to fight COVID.
No, I couldn't agree with you more. Let's talk a little bit about testing, right? Because I think we hear a lot about testing, right? are the rapid home tests effective? Are they not? Should I get a PCR? So if you are living with someone or working with someone and you become exposed to COVID, what should your first move be? Do you run to get a test right away? Do you wait 3 days? Always that information is a little conflicting.
Yeah, it is conflicting, and there's so many variables. Because one thing is, I am at work and the person sitting, or I'm at school, like my kids, and the kid sitting 3 seats next to me now is positive, right? Well, was the kid wearing a mask? Were you wearing a mask? Or was totally unprotected, right? And that's very different from I live at home and my partner or my spouse or my children now are positive, because you're breathing the same air. In Miami, particularly, or South Florida, we have air conditioning everywhere, so the air is recirculating, right? Where now the weather is a little nicer, but usually it's very hot and humid, so we're all breathing and breathing the same air, so higher chances of transmission. That's why we always say that the summer in Florida is the winter in the rest of the country, and that's why we saw that surge in the summer, because everybody's indoors and with air conditioning. So what happens with the antigen is that the antigen test is not as reliable as the PCR. The PCR is sort of what we call the gold standard, is the best test. But it also has its issues. It's so good that sometimes it can remain positive after 3 months. So these are the people who recover from COVID, are totally fine, and a month later they want to travel or they want to be, at work, and they're still testing positive and positive. And it's this like, why is the PCR still positive? Because it detects pieces of your RNA and it can still remain positive depending on the testing platform. And some testing platforms are like the super, super accurate sensitive, and there are others that are less accurate. So the one that is super, super accurate can see everything, can see your retina, let's say, right? The other one can see your eye.
Right.
So that's the PCR. With the antigen, what we have learned is the antigens are good. The government is actually distributing free antigens, which I think it's an excellent idea, because we want people to be able to afford the testing, right? Not to be waiting in line for 5 hours or to have to pay $100 or $60 to get a test in the pharmacy. So delivering them and having them free, I think it's a great move. What do we want? The problem with the rapid antigen, if you are in contact with someone that has COVID for sure, and you didn't have a mask, and you know that you were a high risk infection, you should isolate. That's the first thing I recommend, right? Don't go out spreading the wealth. Keep it at home. And the second thing is you can do a rapid antigen. If the rapid antigen is positive, you don't need a PCR. The rapid antigen is positive. If the rapid antigen is negative, you need to repeat it in a few days. Because we know that serial testing gives better results than no testing. So I've had people, healthcare workers including, that got infected, they were all at a party, and then all of a sudden this person says, I started feeling not too good, I tested and I was negative. So then 48 hours later they went and they tested again and now they're positive. So I had to inform everyone who was in contact with them, hey, I got it. So again, if you're going to do antigen, if it's positive, it helps. If it's negative, you need to do serial testing. Sometimes it takes 2 or 3 to find it. If you're doing PCR is more reliable, but it's also the timing from infection. So if I get exposed to you now, we're both in the same room, and I get it, you just tell me in an hour, hey, I tested positive, we're in the same room just talking. If I test myself in an hour, I may be negative. You need to give time for that virus to replicate. So I can go and get tested now. If it's negative, it doesn't mean that I don't have it. I need to get retested in a couple of days. So we usually say 3 to 5 days from the exposure.
So if I'm at home, right, and my significant other or my child tests positive for COVID and they're, fully symptomatic, and a couple of days later, I develop very similar symptoms, can
You
I
have
just
COVID.
assume that I have COVID?
You
Because
have
I
to,
know it was
even
a
if the test is
challenge.
negative, even if
Right.
the test is negative, you have COVID. If everyone in your house had, yesterday I was talking to a friend, he's like, I had to do 10 tests because they came coming back negative, and I knew I had COVID because my child had COVID. So finally a test came back positive. So why so much variability? I guess it depends on the test, different platforms and accuracy. But if somebody has confirmed COVID in your house and you have symptoms, you have COVID. And even before you develop symptoms, you should have been isolating and wearing a mask and not exposing everybody else, because this thing is super transmissible.
Yeah, that's a very important note, because I know people were struggling for a bit there with this surge to go get testing, and we saw on TV that people were waiting for hours in line. And the question always came up, if other members of my household have it and I'm not feeling sick, I would
Yeah.
assume the assumption is that you all have it.
One
So
of the
now
questions,
we can, yep.
one of the questions from the participants is, what's the rate of false positives with the antigen test? So it's very important that in order to understand that the positive or the negative predictive value, when you talk about false positive or false negatives, you also need to understand what's the prevalence in the community. So when we have a very low prevalence of disease, like let's say 1-2% prevalence, there's more likelihood to have a false positive test, especially with the antigens. But when the prevalence is around 30% in our community, 27 to 30%, the probability of having a false positive test goes way low. Okay, so you're more likely to have a false negative than a false positive. If you have symptoms, it's not a false positive. If you're asymptomatic, I can say why people would question the result, but with symptoms, this is not a false positive, and recovering from symptoms is also not a false positive. So if you're trying to return to work on day 5 and the antigen is still positive, that means that your viral load is high and you're still infectious. So I just want to make sure that when people interpret the test results, you need to understand the context, like do I have symptoms or not? Am I recovering from my symptoms, or this is early? How long ago was my exposure, and what's the prevalence in the community around me? Because that changes. So you can't compare yourself to somebody in another country or another part of the world using the same test. It all depends on what's happening at that time and in that place.
I think when the CDC recently changed the period of isolation, right, from 10 days to 5 days. And there was a lot of, I think, back and forth also of after that 5th day, do I need to have a negative test or not? Do I just, I think the CDC, I may be wrong, you'll correct me, that the CDC said after the 5 days, you can mask for 5 days additional, but you didn't have to have that negative test. What are your thoughts on that?
Okay. Initially, when we started seeing these cases in December, there was a collapse of the system, right? Healthcare workers were falling sick like flies. Other industry, flight attendants, pilots, in other, businesses. So the economy was going to collapse if you don't have people taking care, especially when you provide services, not a product. If you don't have anyone who's providing those services, you don't have anyone to serve your, work in the supermarket, you can't get your food delivered, you don't have anyone driving the trucks, you don't have the nurses and the doctors in the hospital, who's going to take care of the patients? So there was a major crisis, as if people are, everybody's quarantining for 10 to 14 days, well, guess what? Half of the workforce is out at the same time. So the CDC had to make a rapid decision, the same way in the UK, to figure out, okay, how do we reintegrate people to come back to work if you're an essential worker? And then when is it safe for the rest of the community to come back? And the initial thought was that Omicron transmission, and what we saw in other variants, is that you usually transmit the most when you're pre-symptomatic, right? Those days right before you develop the symptoms, that's when you have the most amount of virus, and then 2 to 3 days after. So they felt that, well, if you were pre-symptomatic and now your symptoms are better and your symptoms have resolved, then on day 5, you should, in theory, should not have as much virus. You should be able to come back to work. The way we implemented it at Jackson was you needed to get tested. We were not allowing anyone to come back to work because we take care of patients. I don't want our healthcare workers giving COVID to the patients, right? We also have immunocompromised, vulnerable patients. So ideally, people should be testing. When I tell you, day 5, go out, put a mask, guess what? People don't put the mask and people just go out. And right. That's what we're seeing in Miami. So that's what I'm afraid a little bit. If you go to other parts of the world, in Europe, everybody's wearing a mask. You're crossing the street in Spain, everybody's wearing a mask outdoors, indoors, everybody's showing their certificate of vaccination. You come to Miami, it's like the pandemic is over. Nobody's showing any certificate of anything. Nobody's wearing a mask indoors or outdoors. You go to weddings, bar mitzvahs, parties, whatever, communion, quinceañera, is like, woo, no COVID in December. So I feel that you need to understand that if you're going to apply this, law that, we just trust you. Well, you need to understand that people are going to do whatever they want. They're not going to, not everyone is going to wear a mask and be conscientious of protecting others. That's why I felt that retesting at 5 days was more prudent, because I don't want people who are still infectious going out and spreading it to everybody else. There's no way to control it.
One of the questions that we're getting is about just that, but about schools requesting 10 days still for kids while adults are doing 5 days. Is that commonplace, and why would that be? Do you think if that's the case, do they think children carry the virus longer than adults do?
No, I'm seeing that adults and children are carrying it. Some of them carry it longer than others. There's recent data that was published that shows from, I believe it's Japan, that actually the virus is peaking on day 6. So it's not that on day 2 or 3 your virus is gone. Some of the data in Japan is showing that, hey, Omicron is lasting a little longer. So I think I don't have data that children are different than adults. I do know that immunocompromised people do shed longer. And we've known that since the beginning of the pandemic and with other viruses. So I'll give you an example. Our transplant patients, some of them can have extended periods, like weeks or months, still testing positive with infectious virus. So we usually isolate transplant patients 20 days, not 10 days. People in the ICU who got severe disease, we usually isolate them longer, 20, 28 days, not just 10 days. Why? Because we know from our data that these people tend to shed infectious virus. The problem is not just testing positive with a PCR, is how infectious are you. So with the antigen, your viral load has to be very high for the antigen to be positive. So that's what I say, if on day 5 or 6 your antigen is still positive, you're very infectious, because the antigen doesn't pick up when you have a little virus. Usually you need to have a lot of virus for the antigen to be positive. So I don't know why the schools have not changed the guidelines from 10 to 5. I'll tell you, I see the school a little bit like I see the jails. And in the jails, I'm still maintaining 10 days. Why is that? In the school, especially depending on the age of the children, I'm not talking high schools, I'm talking the younger ones, it's very hard to keep a mask on a child,
Right.
especially if they're under 3 and they're playing and they're interacting. So if they're coming back on day 5 and they're still having virus or they're still having some cough, that's a highly transmissible environment, right? The kids touch everything, they'll play, they're in very close contact. Not the same as in adult office where you can, put some other barriers in place and keep their mask on. In the jails, which we oversee at Jackson, it's a big challenge. You have 20, 30, 40 inmates in one cell. Some of them are immunocompromised, some of them are elderly. This population already has some behavioral issues, right? I cannot keep people, this is their home, so I cannot keep them with a mask all the time. So when one person comes infected, it spreads like wildfire, and we have 4 or 5,000 inmates in the jails, and the crime has gone up in the last year. So even more people are getting arrested. What I want is like tell people to behave and not get arrested, so I don't have problems in the jail. But in the jail, we isolate them longer because it's not the cleanest place. It's not this, it's a confined environment. People are sleeping and living in the same quarters all day long, and it's highly transmissible. So we need to protect everybody else. So depending on the patient populations, you may need to isolate them longer, but I'm speculating that that's what the school is doing. I am not sure.
So let's talk a little bit about antibodies, right? So a lot of people will go, and you'll have to excuse me if I don't have the right terminology, but a lot of people will go to their physician, right? And they'll want to see what level antibodies they have, and they'll give them a number, right? And that number, many people don't know how to A, interpret it, or B, they'll think, oh, if that number's high, that means my antibodies are high, so I'm at a very low risk of contracting COVID. What can you tell us about those types of tests and the validity of them?
It has been one of the other challenges of the pandemic, and again, everything with this virus and with the pandemic changes very quickly. So whatever I tell you today may change in an hour or in a week, right? Something else gets published. There are different types of antibody tests, right? So initially, the antibody tests were created to detect if you've had a previous infection, sort of to figure out, hey, have you had COVID exposure and or not, right? And then people started extrapolating that to the vaccines. Oh, but there was never a magic number, and there's no consensus of what is the magic number. There are companies now that are trying to sell us predictive scores and different things, but the antibody tells you part of the story. We have a cellular immunity and a humoral immunity. The antibody is measuring sort of your humoral response, but the cellular response, only in research labs we can do it. So when you have an infection like a virus, you need to know how much is neutralizing the virus and how much is your T cells fighting it versus, your antibodies. So it's a bit more complex than just looking at a number, right? And as opposed to other infections, we don't know what's the magic number. So far, I don't know if 500 is better than 1,000. Or 1,000 is better than 500, or what is the difference? If mine is 500 and yours is 540, is it that you have more protection than me? We do know that people who don't have detectable antibodies, let's say they had COVID or they had the vaccine and they had a booster or they had 3 doses, and still don't have antibodies, we have a problem there, right? They're not mounting an immune response. So in those, I think it helps you the most when you know that you don't have detectable antibodies, because it tells me like, my immune system is not responding. We need to do something else with this person. The other side of the spectrum is people tell me, oh, my antibodies are 1,000, so I don't need to get a booster. I don't need to get this. We don't know yet for sure. I know people that have antibodies of over 1,000 and they still got COVID. I have patients, some of the immunocompromised patients who have antibodies more than 1,000, IgG more than 1,000, they still got COVID and they're still hospitalized. So I'm trying to understand why someone immunocompromised is still with detectable antibodies getting so sick. We're missing something here. And then for most immunocompetent people, having antibodies is good. It tells you that either you had it or you have detectable antibodies, but these antibodies are against the original strain. They're not against Omicron. Unless you got Omicron now, you won't have antibodies against Omicron because the vaccine doesn't have those antibodies. So on one end, I tell people, if you got Omicron, it's bad, but if you got it, you sort of got a natural booster, sort of your natural antibodies. How much is that going to protect you from other variants? We don't know.
And as it relates to, the monoclonal antibodies, the different treatments that are out there, right? Whether it be Regeneron, which I've heard hasn't been necessarily as responsive to Omicron, and now there are ones that are maybe a little bit more responsive. There's medication that's out there for immunocompromised patients, and there's oral medication that Pfizer is putting out there. Talk to us a little bit about those. What are the differences? And if someone had an interest, right? I'm a cancer patient. I want to get the one that I can get that's for preventive purposes, or I'm COVID-19 positive. What's kind of the criteria for me to receive one of these?
Do you mind if I share a slide? Because I think it would be helpful
Sure, absolutely.
to show this visually. So let me share. Can you see my screen?
Yes.
Okay. So these are some of the options that we have to treat COVID right now. Regeneron was a phenomenal monoclonal antibody. We started using it very early, both in clinical trials and clinically, in preventing people from getting COVID, like post-exposure or pre-exposure prophylaxis. Like somebody said, I was in contact, but I am not yet positive. I'm going to give you Regeneron to protect you, right? Or in people who actually got COVID and we gave the Regeneron, within 24 hours, they were feeling better. With Omicron, it's not working. It's resistant to Omicron. So we have been seeing people getting it and still get sick. So we're not really recommending Regeneron. We have been using it because it's the only thing we can offer, but we at this point feel that we should not be giving more Regeneron because it's really like giving you a placebo, okay? The other options, the other monoclonals, there are two. There is Evusheld and there is Sotrovimab, which is here in number 2. Sotrovimab has a relative risk reduction of 85%. So still, it's not 100%, okay? So some people are getting Sotrovimab, which is the monoclonal, that the only one that has activity against Omicron, but it's still not 100%, okay? It's safe in pregnancy. It's a 1-hour IV infusion. Regeneron, we were able to give it intramuscular. Sotrovimab is applying for the FDA approval, but it's still not approved for intramuscular. The Sotrovimab, we have very, very limited capacity. And this is the one that was in the newspaper. Then they send it to other places and we were not getting enough. And then the other one, the Evusheld, the same thing. They sent it to some clinic in Broward and some of our health systems were not getting it. Now, most of the hospitals in Miami, especially us that we treat cancer and transplant, we're getting it. The supply is very limited. So we cannot just open it and give it to everyone. We had to create a tier priority group. Who are the people who are most likely to die if they don't get the monoclonal? And that's our transplant patients. Transplants with rejection, transplants recently transplanted, people who are not mounting a good response when they get the infection. So we're prioritizing to them, to patients with cancer or primary immune deficiencies. And then also with advanced AIDS, we just started to expand this week. That's Sotrovimab. The Evusheld, which is the other monoclonal, is for people who are not yet exposed to COVID. They're not positive, but we know from the immune system that they are getting vaccinated and they're not mounting an immune response. So it's sort of a pre-exposure prophylaxis, not for the treatment, but for pre-exposure prophylaxis. And again, it's not 100% effective either, but it's what we can offer to the highly immunocompromised people who you know that they got 2 doses, a third dose, and a fourth booster, and they're still not mounting antibodies. We're offering them the Evusheld sort of as a shield of protection, right? You still need to wear a mask and do everything else. Now, what about the antiviral? So those are the monoclonals, right? Regeneron, sotrovimab, and Evusheld. The oral drugs, this is the Paxlovid, which is the one that Pfizer approved. It's nirmatrelvir. But the commercial name is Paxlovid. Paxlovid is very effective. The risk reduction is 88%. It's very efficacious. It's a pill. It's a 5-day pill, and it's being prioritized to people that are in moderate to severe high risk, right? Not for the 13-year-old healthy kid or for the 30-year-old healthy person. It's really for the high risk, moderate to high risk people. The problem with this drug is it contains something called ritonavir. And ritonavir is a drug that has a lot of drug-to-drug interactions. So some of our patients that are transplant and HIV cannot take ritonavir because it alters all their other medications. So if you're taking other medications and your doctor prescribes Paxlovid, I want to make sure that you're highly educated enough to look at the drug interactions, or tell your doctor what you're taking so there are no drug-to-drug interactions. That's really, really important because you don't want to cause more harm. The other oral drug is molnupiravir. It was also recently approved and it's available. We don't have a Jackson Paxlovid or molnupiravir, but it's available in some commercial pharmacies. The state has been distributing it to commercial pharmacies like Publix. The risk reduction with this drug, with number 4, is only 30%. So would you take a drug that it's more likely to improve your infection by 88% or something that is just going to give you a 30% chance, right? So this one doesn't sound so good. However, besides the low efficacy, the main concern I have with this drug is that it has some mutagenicity and teratogenicity. So think of it more like thalidomide, right? So you don't want to give a medication that can then cause birth defects or that can potentially in a few years give you cancer. So I would recommend a lot of caution with molnupiravir. And then the one, number 3, is our workhorse in the hospital, is the remdesivir. It's an effective drug. It's an IV infusion, and you need at least 3 to 5 days. So that's sort of what we have. I hope I clarify a little bit the differences between the monoclonals and the antivirals and when we're choosing one or another.
No, that's extremely helpful because we get questions about that all the time, and the availability of it in the state and where it's at. So we appreciate that. Let's talk a little bit about vaccines, right? And boosters. So I think it's in Israel, maybe they've started already with the 4th booster. When do we think that'll happen in the US? Do we think it's imminent and it's coming? And then, there are some questions that have come in, and I'll ask you after about, young boys, I guess teenage boys, and the booster shots and the cardiac issues that we're seeing. So we can talk a little bit about those things.
Okay. So what we know about the vaccines is that for immunosuppressed patients, right? If anyone in the foundation has family members with active cancer, chemo, or transplant, they need 3 doses. So what we call the booster for the rest of the general population, it's part of their scheme. It's 3 doses. And the 3rd dose should be within 20-30 days from the 2nd dose. So they need 3 doses, and then the 4th dose is their first booster. And now the recommendation is 5 months after their 3rd dose, immunosuppressed patients should be getting that 4th dose. So for immunocompromised people, it's already approved, okay? And these are the people that most likely need that 4th dose. Now, what about the rest of us? What about the general population? Because I already have a lot of people calling me, right? And I don't know you, but I have family and friends in Latin America or Europe or other parts of, so but I got 2 doses of Sputnik, and now I went to Miami and I got Johnson, but I'm going to go to I don't know where to get, Pfizer or Moderna. And I'm like, right. So some people are already taking their 4th, their 5th. They're taking, whatever they want. It's very hard for me to tell people, don't do this. People at the end of the day make their own.
You're frozen on my end, Dr. Abo. I don't know if that's the case for everyone else.
Okay, you're back.
Okay, there you go.
Okay. So the data from Shiva Medical Center, I'm waiting for that publication, but the preliminary data shows that in healthcare workers that got the fourth dose, they still got infected with Omicron. So the data that they're showing is that apparently with Omicron, your level of antibodies has to be so high that not even with a fourth dose or a second booster, we're achieving that. So it may prevent you from severe disease, but it's still not preventing people from getting infected. So far, there is no formal recommendation to when should you get that fourth dose. Initially, we thought that people after 6 months, 5 to 6 months, the antibodies are weaning off. But so far, there is no formal guidance, and we have a call with the CDC later this week, hoping that the CDC has some data and will clarify that. The other big question I get is, I got Omicron. When should I get my next booster? I'm going to just go and get another booster. I don't know. So if you didn't get Omicron, if you're like me, one of the Hunger Games survivors that have not had Omicron, I would say maybe in 6 months I may need a booster. If I had Omicron, do I really need another booster right now? I don't know yet. So there has to be also, there will have to be some differences between people who got it and who didn't. And again, how long do your antibodies last? And maybe if we're going to be changing the guidance, should we be requesting that you get antibodies before you give you a booster? How do we interpret those antibodies? So we don't know yet. Information will be forthcoming, and I think we will know more in 2 to 3 months.
What about this issue with that we're seeing the cardiac concerns with teen boys, and should they be getting the booster?
That's a difficult one because most of the data that we saw with teenage boys with the vaccines were reversible cases of myocarditis. The majority of them were completely reversible. COVID itself can give you cardiac disease. COVID goes to the heart, goes to the brain, and as I mentioned, now there's data on young teenagers and kids getting demyelination in the brain and having severe brain deficits from COVID. So I would say if I have to pick on having a side effect from the vaccine or the virus, I go with the vaccine that are well more studied. Now, the data on vaccinating the boosters for teenagers, the WHO came out today with the guidance saying that there's still not enough evidence to support that we should be giving boosters to teenagers and children. So there is some conflict between what CDC is recommending and WHO. My daughter already got her booster. She's 17. My son is 14 and was vaccinated in June, and he hasn't had a booster yet. So I am, I'm reviewing first the evidence, like how likely is he going to get severe COVID if he had already a vaccine in June, before I make the decision. Maybe I need to give him the booster in a few weeks or in a few days. So the likelihood of myocarditis exists. Yes, it's not negligent, but it's vast majority of the cases have been reversible. And I would say if you have children, weigh your risks and benefits, right? What are their underlying illnesses, risk factors? If your child has diabetes or it's obese or immunocompromised, I think that will be different from a healthy 12-year-old.
So let's go through some of these questions that we've been getting now from the participants. So this is a specific question that says, symptoms kept happening after my COVID test was negative. I was very fatigued a week after. How long do these things linger for? And is that common that symptoms turn up after testing negative and not having had them while you were positive?
Yeah, it's not very common, but it has happened. I've seen people who initially the first few days they were fine. They thought that they were negative, and then all of a sudden they start feeling worse and more fatigue and more tired. This virus is again, it's a bit unpredictable. Like some people are feeling fatigue for months. I've seen patients that 2 months later they're still feeling fatigue. We've had healthcare workers that say my brain was not functioning, for 1 or 2 months even after the COVID. And these are highly functional people. These are, one of my colleagues was telling me I couldn't even open my door. I was getting the keys and I couldn't remember which one was the right key to my door. So it's reversible, but I know it can be concerning, especially if you're a highly active person, all of a sudden you're feeling fatigue. It's not uncommon. It doesn't happen to everyone, but it's not uncommon.
Excellent. I'm going to share a little bit of a personal story here. So I had COVID in June after having been vaccinated. So one of those breakthrough cases, right? And since then, I forget everything, right? And I thought it was just me being forgetful. And then I learned, what they call the COVID fog or COVID brain or whatever. And I'm wondering how long it's going to go on for, but it's pretty intense. Like I'll forget something that happened a day ago or 2 days ago. It's gotten better for certain, so I'm hopeful. But yeah, like this individual said, obviously been negative for a really long time, and so these symptoms linger. So hopefully that won't be the case. I was equating it to my age. I was like, is it my age? Am I having senior moments, or is it what they call this COVID fog? So
And thank you for sharing your story, Flavia. And I'm glad you recovered and that you're doing well because we need you. Uh, but one of the things is now that we're understanding more the disease, it's exactly what I'm mentioning is this demyelination. These brain cells are being attacked. Initially, we thought it was just a cold, right? You don't have any neurological symptoms, but there are other people who have had severe neurological disease. Even from the beginning of the pandemic, we've seen people the NIH actually conducted a full webinar on this, and there are ongoing studies. So if you have lingering symptoms, you can check the NIH website. There are ongoing studies trying to study this long-term COVID. There are people who had $1 million workups, from MRIs to seeing psychologists, psychiatrists, different specialists trying to figure out why they're having all this neurological impairment. And so far, most of the studies have not revealed anything like nothing, not a mass on the brain or anything like that can be removed. But it is really the inflammation on these neurological cells and, the myelin, that it takes time for it to regenerate and recover. That's sort of, I'm hoping that the majority of the people are having this reversible. The fatigue is eventually resolving. But yes, some symptoms, even with Omicron, that it's supposed to be milder, some people have prolonged lingering symptoms.
here's another question. Why should I get vaccinated if I had COVID the first time and now reinfected with the other? Did that give me natural immunity? Is there something in the vaccine that will protect me further?
So what we've learned is that people who had COVID the first time in the last year and a half and were vaccinated have been less likely to get severe disease. Whether they get infected with Delta or with Omicron, the vaccination gives an extra layer of protection. And I have a chart on that as well. It's what we call them the superhumans. So if you had an infection and on top of that you vaccinate, you're a superhuman. Your level of antibodies is much higher than someone who only had infection. So that would be the argument to tell you you should consider the vaccine, because you will be a superhuman in terms of more protection than someone who never had, or someone who had either one, the vaccine alone or the infection alone.
And then this question here that we got, this is something I hadn't heard of. So from one of the attendees saying there's rumors that China may be closing again. Does this mean that there's another variant? How often does the international world share information with others regularly on their findings to help the rest of the world when the virus travels?
That's a beautiful question for the United Nations, right? So I'm biased as Venezuelan, all right? So you're talking about China, where democracy is not the theme, right? It's like saying, but Cuba is not reporting infections, or Venezuela is saying that nothing is going on. And we have a parallel network of epidemiologists working really hard to capture what's really happening because the government is hiding it. So does the world share information? Yes, and information is shared in real time. And that's one of the beauties of living in the 21st century. We had the information in late November, early December of 2019 that there was something happening in China. The Chinese government was not reporting it, but there were leakages of information. And as soon as the virus started to spread, they were able to sequencing. Within 2 weeks, the virus had a name, a sequence, and they were already starting to work on a vaccine. So information is shared around the world. However, in certain countries, that information is not as transparent. Right now, Mr. President Putin is, in Ukraine with all his army, saying that he's not going to invade, that he's just exercising. But how much is he really sharing with the rest of the world and the United States? So I think, like in politics, And in war, the same thing happens, unfortunately, in science. Not everyone shares the same information. But in other parts of the world, yes, the information is shared very quickly. And there's some information that is shared at a very high level that the CDC and the WHO may know that we still don't know at our level, because there is very close communication. Like the South African variant, CDC already had information before us on how this was being spread, sequencing and sharing between laboratories the information, trying to predict. However, going back to your original question, there is an urgent need for more collaboration, and not just with COVID, but with future pandemics. And the preparedness has to be global. The world was not prepared globally to face this. And we have health disparities. We as Americans, we want to make sure that we in America are taken care of. But when we started developing the vaccines, part of those vaccines should have been allocated or sold to lower income countries. What the Chinese did it, the Russians did it, so the rest of the world is being vaccinated with less effective vaccines. And unfortunately, they don't have the privileges that we have here. So more collaboration has to happen if we want to end the pandemic and prevent other pandemics.
You brought up the topic of misinformation, and I wanted to ask you briefly. We know that there's been so much of that throughout this pandemic. Besides the CDC, right, and the World Health Organization, are there other trusted resources that if someone wants to look up information with regards to COVID or know what's the most current that they could go to?
Yes, absolutely. And like you mentioned, there has been a pandemic of misinformation, which is really hard. And I know the information is also confusing, even from the reliable sources, because the information changes so quickly that even I sometimes have a hard time keeping up with everything that is coming out, right? And then you have to balance, okay, what do I take from all of this? So I follow the ID Society of America, IDSA. It's idsa.org. They have a panel of experts in infectious diseases. I'm part of the board of the society, so I know how reliable is the science behind writing recommendations. And I would say IDSA guidelines and recommendations are quite strong, very well thought, and constantly updated. The second thing is NIH. NIH also has put guidelines for different things in terms of management of COVID. I would say the National Institutes of Health and IDSA are two highly reliable sources. And then for other things, you have the CDC that has information in Spanish and English. I don't think they have the information in Creole, but they have been constantly keeping up to date and with the general public information. But if you're going to choose, should I take ivermectin or should I do that, I would go to IDSA and NIH. They have graded recommendations based on evidence and why we should do some things and why we should not do some other things.
We got one late question in that says, have you seen Bell's palsy reactions after taking the vaccines, first 2 shots? Would you take the booster shot? I am immunocompromised.
Wow, that's a tough question. So Bell's palsy was reported both in the clinical trials and when we started vaccinating healthcare workers. There were reports that Bell's palsy could occur both with Moderna and Pfizer. I personally have not seen it. We have vaccinated over 100,000 people across the community and with our healthcare workers. And I personally did not see any case of Bell's palsy. So if you had Bell's palsy, both with first dose and with second dose, I think that's very strange. I would be concerned that you could potentially get again Bell's palsy with the booster. It's very unusual. I've heard of usually you get it with 1 dose but not with a second one. So I would say you would have to discuss that with your healthcare provider. I don't know what kind of immunocompromised state do you have. We usually recommend to avoid the booster if you have a history of severe allergic reaction or anaphylaxis. Bell's palsy is not one of those, so I would have to weigh your risk and benefit if it's safe for you to get the booster based on your in risk factors and your immunocompromised state, or if you would benefit more from Evusheld, which is the monoclonal. So that's a conversation I think you need to have with your provider.
Thank you. And our final question that we have is, when do you know that it's time to go to the hospital or reach out to your physician if you've been infected with COVID?
Oh, that's a great question. So again, depends on the person, depends on your risk factors. We're seeing a lot of people who don't want to come to the hospital. And I know I don't want to go to a hospital when I feel sick, right? I work at a hospital. But the damage of not coming soon enough is much worse, because if you come early, we can assess you, we can give you treatment if needed, or we can tell you what to do. When you're waiting and waiting at home after a week, I've had a patient who for a week was like, oh, I'm tired, I'm not feeling great. Saturday morning had to call 911, go to the nearest emergency room. It was quite chaotic. The patient ended up in the hospital and fortunately is doing better. But depending on your risk factors, I would say at minimum, have a pulse oximeter at home, right? And the ones from home are not as reliable as the one we have in the hospital, but it's better than nothing. So since the beginning of the pandemic, I bought pulse oximeters. I gave it to my parents. We have them at home. I gave it to my nearest family. And I said, okay, you have this. In case you get COVID, check your saturation. Because that to me, if the O2 sat is dropping, that's one of the indications you need to go to the hospital, right? Oxygenation should always be more than 94, 95%. You shouldn't be saturating 90, 91%. That's low. If you're fine, if you check your sat, but then you start walking or exercising or just taking a shower and you start feeling winded, check your O2 sat while you're exercising. If it drops, you have to go and get medical attention, right? So it's not just at rest, but also when you're exercising or minimal exertion, you need to make sure. If you have fevers that are not going away, like 2 or 3 days of fever and fevers are not improving, I think you should call your doctor. Now we have telehealth. People can, have access to that as well. If you're afraid of going to the hospital, at least a telehealth visit that somebody can see you in a camera and determine what else is going on with you. And again, the immunocompromised, very low threshold. Cancer, transplant, very, very low threshold because COVID causes dehydration very quickly. Our kidney transplant patients and their creatinine starts going up. I usually tell them, call your transplant team. If you're here at MTI, call your team, let them assess you. And if we need to give you the monoclonal, the earlier you get the monoclonal, if you're immunocompromised, the better. The monoclonals act the best if you get it in the first 2-3 days, not in the first 9 to 10 days. So again, depends on your risk. If you're obese, diabetic, lower threshold to call your provider because you have a higher risk of progression. And if you're not vaccinated, you have a higher chance of getting sicker. So not everyone, some people are doing okay, but the majority of unvaccinated are the ones who get worse. So if you're unvaccinated, I would say seek medical attention sooner.
Is there a final message you'd like to share with our participants today?
No, well, I first want to thank you and everyone again for the opportunity of staying with us for an hour and listening and the great questions. I know it's exhausting. Many of us are burned out from the pandemic, but again, put things in perspective. Gratitude, mindfulness. I know it sounds tacky, but it does work. Think every day what something positive you can do for your life and for the community. Many of you in the foundation are doing amazing work. Focus on what's going well, not everything that's going wrong. Listen to the news, but limit it, okay? Focus on not just the bad stuff. There are also great things happening. Wear your mask, get your boosters if you haven't, get vaccinated if you haven't, and this will be over. We just need to keep running this marathon, but we will all get together to the finish line. So thank you again for inviting me.
Thank you, Dr. Abel, so much. We're really grateful, and this was so informative. I know that I learned a lot, and I'm sure that our participants did as well. So thank you for taking the time.
Thank you, Flavia.
Have a great day. Bye-bye.